presented by Dr. Prakash K, a prospective randomized trial on use of octreotide in patients with soft pancreas undergoing pancreatic duodenectomy. Dr. Prakash.
This is a prospective randomized trial on the use of octreotide in patients with soft pancreas undergoing pancreatic duodenectomy. This comes from the Department of GI Surgery, PVS Memorial Hospital, Kochi. We all know that pancreatic fistula is a major cause for morbidity and is strongly linked with death in many cases. And it prolongs the hospital stay, and we all know that in those patients there is a lot of use of resources and more expenses. And if you look at the type of the gland we handle, there are low risk and high risk glands. The high risk glands include the soft glands, or those with normal texture and normal small size ducts, typically in a small periambulatory tumor or an islet cell tumor. And there are other factors put forward. And it is in this subgroup of patients, there is always a question asked that whether octreotide is helpful in this high risk group. And the study addresses this issue. And there have been many randomized trials in the literature regarding somatostatin or octreotide in this setting. This is the latest Cochrane review table showing that 17 randomized trials, and it has, in the conclusion they have put forward that there is slight advantage in terms of improving the pancreatic fistulae with the use of somatostatin analogs. But mind you, these are all trials before the IASGCON definition, and the bottom half, the 3 trials have shown the clinically significant fistulae, and that doesn't show much difference. And there are a lot of criticisms with all these trials. Most studies handled heterogeneous group of patients, meaning they have included chronic pancreatitis, they have included hard pancreas, soft pancreas, everything. Different types of procedures, LPJs, distal pancreatomies, Whipple's procedures. And we all know that IASGCON came in 2005, and the definitions were standardized after that. So the reporting was not homogeneous in terms of fistula reporting. And all the studies have commented that octreotide is potentially beneficial, or is it useful in high-risk glands? That's the question which is unanswered. And this study, which is registered in the clinical trials, was on this basis. It's an open-label study which included octreotide in one arm for 5 days and standard care, and there was a provision for crossover if the patient develops an obvious fistula. And assuming that there's a 20% reduction if you use octreotide, with statistical power of 80%, we assumed that around 108 patients were required to complete the study. So the aim of the study is to assess the role of octreotide in pancreatic fistulae in soft pancreas with non-dilated, very focused group. And the primary endpoints were pancreatic fistulae, complications, morbidity, and hospital stay. So it's soft pancreas with non-dilated duct, and exclusion criteria include age above 75, documented dilatation on preoperative imaging, documented chronic pancreatitis or previous gastric or pancreatic surgeries. And these were the criteria used to capture the endpoints, and the drain outputs were measured on D1, D3, and D5, and pancreatic fistula was defined according to the IASGCON definition. And the randomization was done on table because the consent was taken before, and the randomization was done when the surgeon finally assessed the gland and thought that it was suitable for continuing. So according to the randomization, we had 40 patients in octreotide arm, 13 were excluded because of some reasons, and this is the outcome. Coming to the results, if you look at the demographic, there is no difference in terms of age, sex, bilirubin levels, albumin levels, or preoperative cholangitis, or use of stents. Those were homogeneous. And look at the glands we handled. The majority, as expected, is periambulatory, 89% versus 87.5%. PD size was 3.3 versus 3.5 millimeters, tumor size 2.8. And the last 3 parameters were surgeon's assessment, friability, eccentric duct, and technical difficulty. These were marginally high in the no octreotide, but not significant enough. And these are the drain output values on day 1, day 3, and day 5. We found that the drain output values were slightly high in the octreotide arm than no octreotide arm. This is the most important slide showing the pancreatic fistula rate. We see that grade A is around 60% in both arms. Grade B, 6 and 5 that is 15.57% and 12.5%. And there is one grade C fistula in no octreotide group, no one in the octreotide arm. And if you put together the grade B and fistula, that those called the significant fistula, there was no statistically different incidence in between octreotide and no octreotide. And this is the graphical representation of the same. You can see that the significant fistula is not different in both arms. And if you look at the postoperative outcome, the day with which the nasogastric tube was removed, liquids, oral diet, the complications, morbidity, everything was similar. And there were one mortality in either group. One in the no octreotide was because of grade C fistula and bleed. The second was an unexpected death, not in hospital, within 30 days in another hospital, which was an acute event. We don't know exactly, it was related to pancreatic fistula. And hospital stay was not different. So to conclude, the results of this randomized trial show that there is no significant difference in terms of pancreatic fistula with use of octreotide and soft pancreas in those with normal duct and high-risk glands. And there is no difference in short-term outcome in terms of morbidity and hospital stay in either groups. Thank you.